Rishi. I'm one of the paediatric consultants at the Royal Brompton. I'm going to give you a quick whistle-stop tour of paediatric sleep and sleep studies. It's quite a big subject, so I've had to be selective in what we're talking about. I'm going to give another talk later in the year, focusing more on OSA and giving you a bit more of the research background into that. The date for that will follow. So a brief overview of what I'm going to talk about. I'm going to define sleep, talk about the physiology, how physiology differs in our breathing, mainly during sleep. Briefly talk about sleep disorders and OSA, but not in any great detail because they need to be discussed individually, I think. How to investigate sleep disorders, how we score events during sleep studies, show you a few case studies which explain why sleep is so good and what we can do and how interventions can make a big difference to our children in a very short space of time. So it can be very satisfying. And then a quick summary of the talk as well. So the Oxford English Dictionary defines sleep as a condition of body and mind that typically recurs for several hours every night, in which the nervous system is inactive, the eyes are closed, and the postural muscles are relaxed, and consciousness is practically suspended. And any disorder disrupting sleep is really important during childhood because the maturation of the central nervous system is ongoing, and developing areas are much more vulnerable to injury that can happen with disrupted sleep. So the medical definition is a sustained quiescence in a species state accompanied by reduced responsiveness to external stimuli. And in mammals, we have a very quick reversal to being wakeful. In children, we know that sleep affects every aspect of their health and daily functioning, which is why it's really important. There are studies that show that if your sleep is disrupted, your physical health and cognitive performance is also impaired. And I can talk about this more at the end if people have any questions, but mainly I'll cover that in the next lecture about OSA. And obviously sleep problems in children can have a whole different impact on the family, because if the child isn't sleeping, then obviously parents, siblings are not getting sleep either, which can have a huge impact, not just medically, but psychologically as well. So although it's a talk on sleep, I do want to keep you awake, so there will be some MCQs throughout the talk. So the first one, just a quick fun one to start with. So wakefulness of 24 hours, some research has shown that if you're awake for this time, what equivalent alcohol content in the blood does this equate to? Is it 1, 2, 3, 4, or 5? So I'll give you about 10 seconds, 15 seconds to vote. Okay, so a variety of answers. Most people went for 0.1, which is the right answer. And if you think about the legal limit in the UK for having a drink and driving, it's 0.08. So staying awake for 24 hours is actually statistically likely to be worse for you than being over the legal limit for drinking alcohol, yet it's not illegal to do this. So food for thought. So functions of sleep are normal growth and development, brain metabolic restoration, and we think that it remodels synaptic function. It's a fallacy that we conserve energy during sleep because you only save 50 calories by sleeping 8 hours, so it doesn't actually stop you expending energy. It enforces immobility, which is a good thing. Everyone needs to rest their muscles. And as I said before, sleep deprivation is very dangerous. 17 hours of sustained wakefulness is similar to 2 glasses of wine, and a lack of sleep has been implicated in Exxon Valdez, Chernobyl, and the Challenger disasters. So it's really important to get enough sleep. So what causes sleep? The sleep-wake cycle depends on the interaction of two processes. Process C, which is a circadian wakefulness drive, and over a 24-hour period, this is established primarily through melatonin secretion, which is mediated by exposure to light, but also by other Zeitgebers, which are external or environmental cues that entrain or synchronize an organism's biological rhythms to the Earth's dark light cycle and the 12-month cycle. And there's process S, which is your homeostatic sleep drive, and this accumulates gradually as you're awake. And sleep onset occurs when increasing sleep pressure, process S, intersects with decreasing circadian wakefulness, process C. And this also involves psychological, physiological, and behavioral components. And this is shown in this graph. So you can see process S in the red and process C in the blue. And when there's the biggest gap between the two, there is sleep onset. And when they meet again, then you wake up. So the sleep-wake cycle is linked to the light-dark cycle in humans. And the circadian rhythm, that comes from the Latin for circa and diem, is mediated by the suprachiasmatic nucleus in the hypothalamus. There are various sleep drivers: the solitary tract nucleus, the Rafe nucleus, the medial forebrain, and hormones IL-1, TNF-alpha, melatonin, serotonin. And alertness is influenced by inhibition of the reticular activating system and PGE2. And this diagram shows you what happens in the sleep-wake cycle. So, early in the morning at 6 o'clock, you get a very sharp rise in blood pressure. When melatonin secretion stops at 7:30, you're likely to have a bowel motion, or that's when you're likely to stop inhibiting the bowel motions. Testosterone is secreted. You're most alert at 10 o'clock. Later in the day, you have your better coordination, greatest cardiovascular efficiency and muscle strength. Blood pressure is highest in the evening, and then by about 9 o'clock, your melatonin secretion starts, which makes you sleepy. Your bowel motions are suppressed, and then your deepest sleep is around 2 o'clock, and by about 4:30 in the morning, you have your lowest body temperature if your cycle is, is as it should be. So I'm going to quickly talk about sleep staging and architecture, because although you go to sleep, around here, and your deepest sleep is here, your sleep isn't the same all the way through the night, and happens in different stages. So your staging of sleep is looked at on what we call a PaeCH, so the polysomnogram, which looks at your brain waves during wakefulness and sleep. And when you're awake, you have an alpha rhythm, which looks a bit like this. And when you're drowsy, your rhythms look like that. And you have non-REM sleep, which is what we call slow wave sleep. It's staged into N1 and N2 and N3. It was formerly N4, but it's now merged with N3. And you have REM sleep, so rapid eye movement sleep, when your motor activity is inhibited, and your sleep is deeper as you go through the stages. And non-REM and REM alternate, and you get brief arousals, and then you rapidly return to sleep at the end of each cycle. And the slow wave sleep, so the non-REM sleep, predominates in the first third in grown-ups, and REM in the last third. So this is an example of N1, what it looks like. You can see the big difference from when you're awake. When you're in N1 sleep, you have a very low arousal threshold, which means that you can wake up quite easily. Normally lasts for less than 10 minutes. And these are called alpha waves, and they're about 8 to 13 hertz. And this is about 2 to 5% of your total sleep. N2 lengthens over the duration of your whole sleep cycle. Initially short and then longer. And there's sleep spindles, which are 12 to 14 hertz, which you can see here. And then there's K complex, which is a biphasic waves you can see here. And typically about 50% of your sleep is N2. You then get N3 sleep, which is delta slow wave activity. The EEG is what we call synchronized, and this is about 14 to 32% of your sleep. And then you get REM, which is high brain activity, the sawtooth pattern, and you can get theta and alpha waves, which are different hertz. And in adults, it's relatively less. In infants, actually, 50% of their sleep is REM sleep. And this just summarizes what I've just said. So stage 1 is sleep-wake transition. And this is when you get the jerks that you sometimes experience and hypnagogic hallucinations. And as I said, you can have a very low arousal threshold in stage 1. In stage 2, this is when you're initiating your true sleep. You're less aware of your surroundings, and you see these sleep spindles and K complexes on the EEG. And then in stage 3, a deeper sleep, also called slow wave or delta sleep, 30 to 45 minutes and a brief arousal. Your heart rate is slow and regular. Your breathing is slow and regular. And you'll see this on the later slides that I show you. And your muscles start to relax as well. And it's thought that non-REM sleep is for weeding and pruning, so basically getting rid of all the rubbish, and it's predominantly in early sleep, and there's minimal EEG activity. And then in REM, all the important stuff, the connections are strengthened, and this increases in length during sleep, so it's more towards the end of the night, and the EEG looks very similar to what it looks like when you're awake. So this just summarizes about REM sleep. The first onset of REM is about 70 to 100 minutes after sleep onset and lasts for about 10 minutes. Towards the end of the night, your REM sleep is about 60 minutes or more. The EEG is desynchronized, very similar to when you're awake. Your brain metabolic rate is the highest that it is at nighttime. This is when you dream, and this is when you have low skeletal muscle tone. It's when you get colder, normal thermoregulation isn't working, and you get episodic bursts of the phasic eye movement, hence the name. And there's increased sympathetic tone, your breathing control changes, and your heart rate, respiratory rate, and blood pressure are much more variable compared to non-REM sleep. And your hypoxic and hypercapnic ventilatory drive are reduced, and I'll show you some slides about this later on. So if you've got any sleep problems, they become much more apparent during REM sleep. So as I said, non-REM and REM alternate throughout the night in cycles, and this is a hypnogram, and it shows you in children, young adults, and the elderly how things are different. I'm not going to go too much into this, we don't have time, but it basically shows you the stages of sleep, awakeness, and REM blocks, and you can see, not as much here, but on the next slide, how the REM blocks change as you get older. By the time you're 6 months, you can actually classify sleep into REM and non-REM. At 6 months, the cycles are about 60 minutes, and as you get older, it's more like 90 minutes. So this is younger children, much more useful to look at this. You can see in 2-month-old babies, your REM sleep is very frequent and relatively longer, and as children get older, the REM sleep onset is later, and the amount of REM is less. By the time you're about 7, your proportion of REM sleep is very similar to what it is when you're an adult. And again, you can see that here. So babies are very lucky, they get 50% of dream sleep, and then by the time you're about 7, it's down to about 18–19%, and it tends to stay around this level for much of the rest of your life. Sleep requirements, so newborns sleep a lot. As you get older, you get down to about 8 hours, although people say that you need 8 hours. Lots of people get less, but there is, as you've seen in my first slide, evidence if you sleep for less than 7 hours a night, so equivalent to 17 hours of wakefulness, you are actually not functioning at your best, and it's equivalent to having drunk 2 glasses of wine. So bear that in mind when you're coming to work for a shift and having slept 7 hours or less, you're probably not as alert or on the ball as you should be. Nap patterns, 3 to 6 month olds have 3 naps a day, or should do. 6 to 12 months, 2 naps a day. Greater than 12 months, 1 nap a day. By 3, hopefully no naps. And then you're into your normal adult sleeping routine. As I said before, this just summarizes the developmental changes that I was talking about, with REM occurring later in children. And yeah, I'm not going to go through this actually, because it just basically summarizes what I've said before. There's lots of physiological effects with sleep. So in non-REM, you have endocrine effects. mainly in stage 3. There's an increase in growth hormone, thyroid, melatonin, prolactin, and an inhibition of cortisol. Your cardiovascular system, as I mentioned before, your heart rate and cardiac output go down, as is your blood pressure. You hyperventilate, your respiratory rate is reduced, and the depth of breathing is reduced. You have reduced GFR, and your brain metabolism is also reduced in non-REM sleep. And this is an example of a sleep study with an EEG in non-REM sleep. And you can see the breathing pattern is very, very regular here. In REM sleep, you have a variation in blood pressure and heart rate, which increases compared to non-REM sleep. There's increased, the blood flow is increased compared to non-REM, and it's very comparable to when you're awake. Your neural metabolism increases in the limbic system. Your muscles are very floppy, and your thermoregulation is impaired. And your breathing, as I said, your respiratory function is actually impaired in REM, so you get slightly hypocapnic. Your total ventilation goes down, your respiratory rate goes up, and very relevant to obstructive sleep apnea is that your upper airways resistance increases. And this is an example of a sleep study in REM, and it's a bit difficult to appreciate on this one as much as before, but if you can see, I just want you to look at the breathing pattern, very regular here, and you can see there's a lot more variability in the traces here. So breathing during sleep, sleep alters the function and control of your breathing. Your minute ventilation goes down, your upper airways resistance increases, and your drive to breathe actually goes down as well. So breathing is impaired compared to when you're awake, and it's further impaired in REM sleep than in non-REM sleep. And as children have more REM sleep than adults, you would think that actually any sleep disorders might be more pronounced in children, actually, and that's why it's quite a surprise when you tell parents that their children have OSA, because they imagine that this is a disease of older people who are overweight, but it's not necessarily the case. And mechanical problems are much more likely to appear in REM due to the muscles being much more relaxed. So obstructive sleep apnea, neuromuscular disorders, you're much more likely to get problems in REM because that's when your muscles are the most atonic. So in non-REM sleep, your respiratory drive is reduced, your chemosensitivity goes down, but this fluctuates in N1 and N2. Breathing regulation is by metabolic respiratory control. There's reduced respiratory rate and blood pressure and heart rate and tidal volumes, and this is lowest in N3, and there's a slight increase in your CO2 levels as well. In REM sleep, your respiratory drive is irregular, and infants, your heart rate and respiratory rate are much more variable compared to non-REM sleep. Infants often have periods of apnea up to 10 seconds, usually in REM, but not always. And this can persist up to 6 months, but the SAT should not normally drop to less than 90 during these episodes. So we often get referrals from hospitals asking us to do sleep studies in very young babies because they have pauses in their breathing. And actually this can be quite normal. So it's not necessarily central sleep apnea. So if babies have periods of apnea up to 10 seconds, usually during REM and not always, because obviously the sleep stage is not well defined at that age and difficult to tell if we're not doing an EEG. But the main thing to remember is that they can have them if the SATs do not drop to less than 90. It's not always a problem. We quite often see periodic breathing as well in infants, mainly in REM. And this is basically when you see rapid breaths followed by a pause in a pattern of at least 3 cycles. We get reduced intercostal and upper airway muscle tone, and there's a generalized inhibition of skeletal muscle tone, including the pharyngeal muscles. We need muscle tone to keep our airways patent, and obviously during sleep, reaching in the DIR during REM, the reduction of muscle tone is very important. So this just summarizes what I've said. So in sleep, the ventilatory drive is reduced due to reduced central drive and reduced chemoreceptor sensitivity. Respiratory muscles, there's reduced intercostal muscle and upper airway muscle tone, and respiratory mechanics, there's increased VQ mismatch, increased airflow resistance, and therefore reduced functional residual capacity. So sleep is a major challenge to the respiratory system compared with being awake. And as a consequence, breathing is often impaired, and sleep is associated with a degree of alveolar hyperventilation, even in normal subjects, due to all of these factors. The problem is that your chemoreceptor responses also change during sleep. So this is quite an interesting study. So the yellow line is when you're awake. The pink line is stage 3, 4, non-REM. The red line is stage 2, and the blue line is REM. And on this bottom axis, you can see oxygen saturation. So as your saturations drop, your ventilation in liters per minute. When you're awake, there's a very good response in your ventilation. In REM, if your sats drop, you don't have the same response to hypoxia. And the same applies in response to a high CO2. So as your end tidal CO2 goes up, when you're awake, your ventilation response increases to counteract it. When you're asleep and when you're in your deepest sleep, you have a less of a response. That means that sleep is actually quite a dangerous thing to be doing when your respiratory system isn't functioning properly. So why do we need sleep studies? They're to assess for sleep disorder breathing. So obstructive sleep apnea is the one that most people think about when referring to sleep studies to us. But there's also other sleep-related syndromes. So neuromuscular disease can cause sleep disorders. As I said, that's due to children with muscle problems having worsening muscle issues when they're asleep. Chest wall deformities, obviously lung parenchymal pathology, so interstitial lung disease. There's lots of studies that suggest issues in asthma and sleep. I don't have time to go into all of these today. It's just a brief overview, but for the further talks, we will talk about each individual condition, primarily neuromuscular diseases, obstructive sleep apnea, and also these are very interesting, central sleep apnea syndrome. So CCHS, which is central hyperventilation syndrome, also called Ondine's curse, which means that your response to when you're asleep, you don't have the same chemoreceptor response, you don't respond to a high CO2, and actually this means you're very dependent on the ventilator at night time, because if you fall asleep, your body won't respond to high CO2 and actually results in death if it's not picked up and treated. And I'll show you some slides later on about a child with CCHS who was on a ventilator and how their sleep studies look. Prematurity, basically your breathing control isn't matured, so you can have central sleep apneas as well, as I mentioned before, and brain lesions, so Chiari malformations and other brain lesions can cause central sleep apnea. And again, I'll show you some slides about this later on. So to classify sleep disorders, you can do it simply into something that's intrinsic, so inside the body, extrinsic, so environmental, outside the body, and alteration of your circadian rhythm. So this can be done artificially. So shift work is a classic example whereby you force yourself to stay awake at night time and then sleep during the day. That can lead to various disturbances in your sleep pattern, particularly if you're doing it on a day-night cycle. So junior doctors in particular, there have been quite a lot of studies that show that there are hormonal imbalances caused by doing shift work. There's classifications, and this is the American Society of Sleep Medicine classification, which does it into 8 different categories, so self-explanatory really. And we normally are looking at sleep-related breathing disorders. Other centres do more about parasomnias and hypersomnias, but we are starting to do more of that now at the Brompton as well. So children at risk of sleep disorder breathing, as I said, the main classifications are obstructive and sleep-related hyperventilation and sleep apnea syndromes. So obstructive sleep apnea doesn't necessarily just have to be due to big tonsils and adenoids. If you're overweight, if you have a small jaw, craniofacial syndromes, achondroplasia, trisomy 21 is another big cohort of patients that we look after, Beckwith-Wiedemann syndrome. Lots of children with mucopolysaccharidosis have issues with breathing at night time. There's a higher incidence if you're Afro-Caribbean, sickle cell, cerebral palsy, and children with various brain lesions as well. Then you have other syndromes. We have sleep-related hyperventilation, so CF, chest wall abnormalities, neuromuscular disorders, brainstem issues, neurological issues such as Rett syndrome is a classic, which has a very typical picture on the sleep study. Prader-Willi syndrome, as I said, CCHS as well. So it's a massive cohort of children, and we do lots of sleep studies in these very frequently to monitor for sleep disorders. So for example, our children with trisomy 21, usually in the first few years of life, we do a study at least once a year because they've got several risk factors for sleep disorder breathing, so hypotonia, big tonsils. They also have other typical sleep disorders, very disturbed sleep at night time. On the video, you quite classically see them moving around a lot and sleeping in typical positions. So it's very important to screen these children for sleep disorders. Obstructive sleep apnea, there's a spectrum of OSA. So primary snoring, this is defined as habitual snoring more than 3 nights a week. The prevalence in the general population is actually 3 to 12% in children. So lots of patients will come to your clinic and say that they snore, but it's not always something that is needing intervention. And it's knowing which children to investigate and how to investigate them that's important. Primary snorers don't have apnea or hypopnea or frequent arousals, only problems with their gas exchange. And current theory is that if they don't have any of these issues, we don't need to intervene, but can simply monitor them. Then you have some children that have upper airways resistance syndrome. So they snore, but they also have increased work of breathing and may wake up more at night, but not really have obstructive events or gas exchange problems. This is a very interesting group. It's not clear whether we should or should not be doing interventions on these children, but there is some emerging research that suggests even these children may well have cognitive impairments because they are being more aroused at night time, hence their sleep is being disturbed, and hence their performance at school may be being impacted. So this is an emerging cohort which we need to know more about. OSA syndrome, these children have recurrent, partial or complete obstruction of the upper airways during sleep. I'll show you what hypopneas and obstructive apneas look like. And because they have these problems, they desaturate at night time. It affects their sleeping pattern. And these are the ones that you really need to intervene on because it can have long-term consequences on their development, also on blood pressure, also on endocrine outcomes. And it's very important that we pick these children up and treat them appropriately. And then there's a group that have the OSA syndrome, but also hypoventilate. So you will see that their end-tidal CO2 or transcutaneous CO2 is also elevated. And in these cases, we may need to treat them with non-invasive ventilation to get their carbon dioxide levels down and alleviate their symptoms. It's not a new thing. So in the BMJ in 1889, you couldn't write this now, but this paper said that there was, on some causes of backwardness and stupidity in children, Dr. William Hill, who was from St. Mary's Hospital, and he noted that the stupid-looking lazy child who suffers frequently from headache at school, breathes through his mouth instead of his nose and snores, and is restless, is worthy of the solicitor's attention of the school medical officer. And he also noted that there was often remarkable relief afforded by nasopharyngeal scarification. So removing the tonsils and adenoids improved matters. This is over 100 years ago now, and it was very, very pertinent. So next MCQ, we've been talking about OSA. How prevalent is it in children aged 5 to 12? Okay, so I think most of the votes are in. So most people have said 3%. So it's not 3% actually. The correct answers are, there's more than one, 1%, and 25%. And it depends on how you are defining obstructive sleep apnea. So some centers, and I don't actually agree with this, define obstructive sleep apnea as if you have an AHI, so the apnea hypopnea index, of more than 1 episode an hour. And if you define it as that, more than 25% of children aged 5 to 12 we define as having OSA. I don't think that's right, actually. I think actually we should use a cutoff of 5%. And in 5 to 12-year-olds, it's more like 1% of children. Lower than that, it is, so younger children have a higher prevalence as well. So it's recognized as a common health problem. As I said, the prevalence varies depending on the definition and the study that you read. And as I said, it's a disorder of breathing during sleep, characterized by partial or complete airway obstruction that interrupts your breathing. I seem to be stuck. So you have repetitive events, oxygen desaturations, high CO2 levels, your intrathoracic pressure changes, and you get arousals and fragmented sleep. And as I said, you get long-term sequelae. And if anyone wants to read a very good review paper, this one here is quite useful. So how to investigate? I can do a whole talk on pediatric OSA, and I will come back to that in another lecture, because there's lots of other implications and outcomes we need to know about, but I don't really have time to do that today. So we're going to talk about how to investigate for sleep disorder breathing and sleep diagnostic tools. So as with anything, history and examination is important. There's the Bear's 5 sleep domains, so bedtime problems, excessive daytime sleepiness, awakenings during the night, regularity and duration of sleep are important to ask about, and questionnaires have developmentally appropriate trigger questions. There's the Sherving questionnaire, which has been used since about 2000, which is for children to screen for obstructive sleep apnea. It's such a big problem, we can't do sleep studies on everyone, so the questionnaire was shown to be quite helpful in picking out those children that need a sleep study. I did a study with some colleagues at Great Ormond Street looking at the questionnaire. We found, unfortunately, it's not as good for children with underlying medical problems. So if you want to screen for OSA in your cohort, this questionnaire is very good if they're otherwise healthy. But if they've got any other underlying problems, so trisomy 21, neurological issues, sickle cell, the questionnaire is very bad at picking these children up. So yeah, use it, but use it only in the right scenarios. You can keep a sleep diary, an example of which is shown here. So the parents keep the diary, and they basically tell you when the child is awake and asleep, and you get a good little readout like this, and you can pick up on problems that are occurring, you know, any patterns that are emerging. Talking about sleep hygiene, are they using lots of bright light just before bedtime, and they're watching TV in the bedroom, computer games. So something's going to be fixed just by sleep hygiene, and the impact of you know, a sleep practitioner cannot be overstated, because actually lots of these sleep problems are just due to the child being put to bed too late at night, and therefore their circadian rhythm is being disrupted. So we need to kind of re-educate the parents first of all before jumping into lots of tests that may not be necessary. So actigraphy is very useful. The Actigraph is a miniature watch-like device. So it monitors activity levels for extended continuous periods. And previous work has demonstrated that its validity in monitoring sleep-wake patterns amongst infants, children, and adults. And it's previously been demonstrated that quantification of movement during sleep using actigraphy is correlated well with polysomnography measures of sleep disturbance. So rather than bringing children in for a very invasive study, you know, putting loads of electrodes on, you can just do this. It's small. You can use it over not just 1 day, but 2 weeks. You can use it at home. And you don't necessarily need trained staff to be interpreting the outcomes of it. We use this software to derive levels of activity and inactivity, and you can actually get parameters from this, such as total sleep time, total wake time, the number of time spent awake, and you can distinguish sleep from wake using the Actigraph, using algorithms to quantify the reduced movement that's associated with sleep. So we're not using it very widely at the moment, but we do intend to start using it more. So we've just had a number of these delivered, because we think they're going to be very useful, particularly in the period of COVID, when we can't really bring children in as easily as we were able to before. So other types of sleep study, oximetry, this is oxygen only. It's useful for screening. You only get the number of desaturations and baseline saturations that are done. The benefit of this is it can be done easily in the community. Then you have O2co2 studies, and actually typically before COVID, we were not really doing many CO2 studies in the community, but we actually picked up on these more recently, primarily because we now have equipment that can do the CO2 monitoring for the whole night without the need for the probe to be changed, which was a problem with some of the older equipment. And you've got cardiorespiratory polygraphy, which is one level up from an O2co2, and again, we can do some of these at home now. And then you have a full PaeCH polysomnography, which involves not just looking at parameters of breathing, but also has EEG monitoring, so you can look at the brain waves. And it's only in this study that you can really classify the sleep into the stages I was going into before. We can guess from other studies what stage of sleep children are in by looking at the heart rate and respiratory rate, but really the only way to truly know if children are having REM sleep and non-REM sleep in the usual distribution is through a full polysomnography. So we don't do very many of these actually in our centre, but in the US, this is basically what most children will have. And the Latin is multiple somnolence graph, so it's basically every channel is measured in the full PaeCH. So oxygen and carbon dioxide studies monitor gas exchange. They're very useful, and they involve a pulse oximetry and a transcutaneous CO2 monitor. And they're generally used for patients already on long-term ventilation or non-invasive ventilation. Very good for monitoring neuromuscular patients who are not on non-invasive ventilation. So these children may well develop breathing difficulties as the disease progresses. So your typical example is Duchenne muscular dystrophy patients. And we need to keep an eye on these patients because there's such an insidious onset of carbon dioxide retention. The children themselves may not notice any symptoms. And actually you find that when you put them on non-invasive ventilation, they suddenly say, oh God, I feel so much better, because you've basically made them sleep a lot more consolidated, and you've brought their carbon dioxide down. So some of these children may chronically have been having headaches or, you know, sleepiness in the daytime due to disturbed sleep, and not been realizing that actually something we can do about it. And again, we use these studies to monitor children on long-term oxygen therapy as well. This is an example of a O2co2 study. You can see the CO2 trace here, the oxygen trace here, and the heart rate here. And this is typically, you know, you can see the heart rate becomes more variable, carbon dioxide goes up, the SATs go down. So we guess that this is REM sleep by the variability in the heart rate. And this is typically where you get issues with breathing. Carbon dioxide's gone up and the SATs have gone down. As I mentioned to you before, this is where the physiology becomes much more, your breathing becomes much more difficult in REM sleep. So this is where you tend to see problems happening. This is a picture of one of our old O2co2 monitors. We've got slightly smaller ones now, and they're more portable, so we're sending them out to do studies on patients at home. So that's an abnormal one. Here's an example of a normal one. You can see the oxygen trace is much more stable here. So here's a 95% line. It's not really dipping very low. This is normal variability. Here you can see the dips are much more defined and deeper. Very stable CO2 trace here. This bit's been taken out, so that's clearly an artifact. And then you get the heart rate here, and then you get a readout like this, where it shows you the mean SATs, the minimum SATs, and the time you spent with oxygen less than 90, and then your mean carbon dioxide and a range. And this is what you want to be seeing. You can see that your chest and your abdomen are moving nicely in sync with each other, and there's a nice, good flow trace, and everything's nicely synchronized in line with one another. So child with OSA looks very similar to that previous trace that I showed you. You can see that there's bumps in the CO2, and this is associated with desaturations. And if the oxygen trace was here, you would see that it's typically during REM sleep. You can see REM, and it's REM-related issues where you tend to see the problem. Quite often these children then go to have their tonsils adenoids taken out, and they come back, and it's very satisfying to see that this is completely resolved. Again, child with neuromuscular disease, typically issues in the early course of the illness will happen during REM, and the same with interstitial lung disease. You tend to see the worst problems during the REM sleep. We can't say that it's definitely REM for sure because there's no EEG, but from the cycling of it and the heart rate variation, we are very confident that this is REM-related issues. So the next step from an O2co2 study is a cardiorespiratory polygraphy. So that's got the O2co2, and also you can see respiratory effort, the nasal flow, snoring, you have a video, ECG, and at the Brompton, this is our baseline test to diagnose and assess sleep disordered breathing. And this is the readout you get from a cardiorespiratory polygraphy. So you get your thorax, you get your abdomen, you get the pressure, you get your SATs here as well, and your ECG and your clef here as well. So it's quite a detailed study. It's not the same as a PaeCH because you don't have the EEG recording, but for most of our patients, it's more than adequate for what we need to know. So this is a more detailed printout of the study, and you can see here the SATs are stable and then they go down. So this is the desaturation, and you can see paradoxical breathing here. So before I showed you that the abdomen and the thorax were moving in the same direction. When you have paradoxical breathing, you'll see that one moves up and one moves down. So you know, the breathing is not in sync as it should be. And typically when you get this kind of obstructive pattern with paradoxical breathing, the child then has an issue with their flow. You get desaturation and they suddenly have a breakthrough breath, so and then wake up, have an arousal, and then you know, go back to sleep again. But you know, if you're doing this multiple times over the course of the night, it's obviously not very good for consolidated sleep. Will make you sleepy during the day, and you know, lead to other issues with your cognitive functioning. So you probably don't need to know this in too much detail. So this is how our physiologists will go through sleep studies and score the study. So when you get a readout at the end of the study, this is what it means. So an obstructive apnea is an event that lasts for at least 2 missed breaths, or the duration of 2 breaths, which is determined by the baseline breathing pattern. And the event is associated with a 90% fall in the signal intensity for greater than 90% of the entire respiratory event compared to the pre-event baseline. And the event is associated with continued or increased respiratory effort throughout the entire period of decreased airflow. So you can see that here. There's a desaturation which happens because the flow has reduced just beforehand. And this is happening quite a lot over the course of this epoch. The central apnea is not like an obstructive apnea. This is associated with absent respiratory effort. So the difference is, with the obstructive, there's still the effort there. With the central, there's absent respiratory effort throughout the whole event, and the event lasts for 20 seconds or longer. And you can see here that all of the lines have gone flat. So there's no effort compared to here, where there's still effort happening with the desaturation. But here, there's no effort, and then you get the big desaturation afterwards. So these are central events, which are different from obstructive events. And again, they last for at least 2 breaths, and they're associated with an arousal, awakening, or more than a 3% desaturation or a bradycardia. And then you can have a hypopnea. These can be central or obstructive. So with the obstructive apnea, remember I said it was 90% fall in the signal intensity. With a hypopnea, it's greater than or equal to 30% fall in the nasal pressure. Again, 2 missed breaths, or the duration of 2 missed breaths as determined by the baseline breathing pattern. There's a fall in the nasal pressure and signal amplitude for more than 90% of the entire event. And again, the event must be associated with an arousal and awakening or a 3% desaturation. And again, you can see here there's hypopnea. So there's a reduction in the flow associated with a desaturation. That just summarizes what I've been saying. And I'm going to rush through now because I'm running out of time. This is a full PaeCH, which also has the EEG leads here. And the main point to pick up on this is that, you know, you get the bits here from the cardiorespiratory polygraphy, not breathing and having an event. But what you miss without having the full PaeCH is the fact that you can see arousals on the full PaeCH. This is quite important, you know, for really accurate scoring. We do proxy scoring of these, but, you know, without actually having the full PaeCH, you can't definitely be sure that you're scoring the arousals. Home studies, these are really good because they're more cost effective, they're convenient, they're more representative how you're sleeping at night time. Parents like them, and they say that children sleep better with these. And they get all of the the outputs that we have in the cardiorespiratory study, and we're now sending them home actually with CO2 recording as well. So I think this is going to be the way forward with the COVID restrictions. Really, they're going to be doing more and more of these in the future. They're possible even in young preschool children. The signal that we most often lose is the nasal airflow. Percentage of successful recordings are higher if the studies are set up by trained staff at the parent's home. But obviously with COVID, we can't do this, and it's actually very time consuming. Sensitivity and specificity appear to be reasonably good for moderate and severe OSA. I'm not sure I'd want to use this as a first line tool for other children that have got, underlying respiratory disorders. That's actually wrong now. Most of our devices now we can do end-tidal or transcutaneous CO2 monitoring. So with all that, what is the gold standard for a pediatric sleep study? Is it the least disruptive option to ensure sleep is close to what it is in the home? Is it a full PaeCH? Is it a cardiorespiratory polygraphy? Or is it a pulse oximetry followed by a second line study? So we've got a split of answers, 25% for all of them. So the correct answer is actually full PaeCH. I mean, this is the gold standard, but I don't think you need to do the gold standard every time in every patient, because it's quite a lot of extra analysis. The EEG is, it's another thing that needs to be tolerated by the child, and actually for most of the children that we investigate, the cardiorespiratory polygraphy gives us most of the information that we need. So, in the American sleep literature will say that anything less than the full PaeCH is not, is not useful, but I disagree, and I think actually a cardiorespiratory polygraphy is more than adequate for most of our patients, to be honest. So what is a normal sleep study? Typically, it's an AHI less than 1. It's classified as normal. 1 to 5 apneas, hypopneas an hour is mild. 5 to 10 is moderate, and more than 10 is severe. If you've got a median O2 above 94%, if your mean CO2 is between 4 and 6.5, but the time above 6.5 is also important. Having no more than 4 desaturations and more than 4% in an hour, and no abnormal clusters of desats or a raised CO2. And obviously you have to evaluate the symptoms. So, if a child's got an AHI of 5 but has got no symptoms whatsoever, I think I'd be hard pushed to say you must have an intervention. So it depends on how the child is. You don't just use the numbers to determine what we need to do. So I'm very quickly going to whiz through some case studies. So we've got a 5-month-old ex-premature baby on CPAP. This is their cardiorespiratory polygraphy. You can see that the CO2 trace is showing a high CO2. The mean is 8.7, even accounting for all the artifact we've got here. The SATs are all over the place, came up to a mean of 93%, which obviously isn't very good. The number of desaturations per hour is 35, and as I said before, it should be no more than 4. And the CO2 is also very high, and the range is high, and the amount above 6.5, which is very important, is very high, 98% of the time. So clearly, this child is not doing very well on the CPAP. So, they're still quite young. 6 centimeters isn't a small amount for a child this old, but clearly we're not winning. And if we don't do something about this, the child's not going to have a consolidated sleep. So we change the child to BiPAP, and the pressure of 18 on 5. So you keep the PEEP at 5, so just a bit above the CPAP they were having, and gave them another pressure on top of that, and they had a backup rate on this. So with BiPAP, you're actually synchronizing their breathing pattern with the machine rather than just giving them constant pressure. And you can see the trace already is much better, much less desaturations, and SAT's 96%, and the mean CO2 is now normal. So this is very satisfying. You do this, and the next night the child has got, you know, a much better sleep study. And you can see on the video that we have with these that the child is actually sleeping a lot better throughout the course of the night. This is another patient, a 7-year-old with CCHS that I mentioned before. They typically have this fluctuating CO2 over the course of the night. And unlike other people, their worst symptoms are actually during non-REM sleep. And you can see in this patient that their CO2 is high, 6.93 over the course of the night, with 63% of the time spent above 6.5. And this child was ventilated via a tracheostomy. And we noticed there was quite a big leak with this tracheostomy. So we changed the tracheostomy, upsized it, and you can see that the trace the second night has come down to a nice CO2 of 5.3, and the mean is 5.3, and the above 6.5 is now only 5% of the time. And the SATS trace is also a lot better just by upsizing and reducing the leak that this patient has. And lastly, this was a 16-year-old girl with a Chiari Malformation. She was on BiPAP. This was her study a few months prior. You can see a very nice SATS trace, the odd desaturation due to a reduction in flow, but not very many. A few months later, she came in, and I was shocked to see that she was having all these central events. So you can see that the whole of the traces are flat, lots and lots of central events causing lots and lots of desaturations. And the number of desaturations, this is one section of the study, is huge compared to before. You can see just the odd one. And this is the sort of readout that you get from the sleep study report. And you can see that her central sleep apnea index in September 17 was 2.2 events an hour. So that equates to this one here. In September 2018, this was a routine screening study she came in for. We were shocked to see that her number of desaturations had gone up to almost 40 an hour, so a 20-fold increase. The worry with this is that she's got a Chiari Malformation, so has something happened to her that's putting more pressure on the brainstem, and she actually was referred back to Great Ormond Street, had an MRI, and it was found that she had worsening of her Chiari Malformation, and she had to undergo emergency shunt surgery. So this is quite an important pickup that we did, and it shows that sleep studies are not just for children with OSA, but can be very important to pick up other conditions. So sorry for the speed, but it's quite a whistle-stop tour of quite a big subject. So sleep is vital for normal growth and development. Our physiology is significantly altered during sleep, and our breathing difficulties are much more likely to manifest, particularly during REM sleep. Sleep studies are really useful to guide respiratory management for patients, and not just putting on ventilation, but as I mentioned in the last case report, children may need surgical intervention of the brain, for example, if you see some issues with their sleep pattern. And it's really important to pick the appropriate test for the appropriate clinical question. You may need ENT intervention. You may need to start NIV or oxygen. And we need to be alert to any unexpected change in the clinical condition and bring children in or do another study at home if more symptoms are being reported. And OSA can lead to significant cardiovascular, metabolic, and neurobehavioral morbidities. OSA is mainly treated by adenosine but we may need to do other treatments for it. And I haven't had time to show you, but there's been a recent ERS task force which gives you a very nice flow chart to guide your investigation and management of children you suspect with OSA. I'd like to finish on W.C. Field saying that sleep is the most beautiful experience in life except for drink. And I've got a few minutes for questions if there are any.
Rishi, thanks very much. That's great. If anybody wants to ask questions, please stick them up on the chat or just speak. I'm going to take privilege and ask the first one. So a lot of people will on this call will be seeing kids like with Down syndrome. Should every child with Down syndrome get a sleep study?
I think every child with Down syndrome under the age of, well, before the age of 2 should have a sleep study. because quite often we won't pick up. Parents won't know what to look for, and I think they've got so many risk factors. The macroglossia, the adenotonsillar hypertrophy, the hypotonia. I think every child under the age of 2 should have a sleep study before the age of 2 with Tri-Suite 21. And then based on that first study, we can decide on follow-up. I think if they've not had issues and they're getting to 5 and they've been completely normal, then we can say that you don't need to have a study. But I think every child should have at least one, if not an annual screening study up to the age of 5. And they have so many other sleep disorders anyway. They're typically very disturbed. It's quite good for parents to know that this is normal. We get to see them on the video, and we give sleep counselling. I think it's really important to do every child with Down syndrome at least once. Yeah.
That's great. We're up to 9:30. Are there any other questions at the moment? I'm sure Rishi's very happy to be emailed if you do have questions. So taking silence as everybody's either asleep or drinking. Rishi, thanks for a really great talk. We're going to have a month's break in August from these sessions. We restart the first Thursday in September. Do please email me with suggestions, stuff that you would like, and have a great summer break. And Rishi, thanks again for taking the time to prepare such a great talk with such a lot of information. Many thanks indeed.